and welcome to the fifth installation of our series on the Arizona Pain and Addiction curriculum. This module is focused on how to use a socio-psychobiological model to develop a whole-person care plan and prevention strategies for persons with pain and/or opioid use disorder. Specifically, we will discuss how the treatment of pain and opioid use disorder requires a socio-psychobiological approach, describe how specific attention must be given to prevention and risk mitigation strategies, and describe the need for an exit strategy to minimize opioid-related adverse events. Following a whole-person evaluation of the person with acute pain, it is appropriate to address the underlying condition with specific treatments and a stepwise approach. It is also necessary to help the patient obtain realistic expectations regarding the duration and severity of expected pain. There are 3 steps to pain management. The first is the use of non-pharmacologic therapies. This includes things such as self-care like ice or rest, complementary therapies like massage, rehabilitation therapies like physical therapy, and exercise. Acute pain usually resolves, and patients may only need these interventions for a short amount of time. Step 2 is to use non-pharmacological therapies plus non-opioid pharmacotherapy, such as NSAIDs, lidocaine, or muscle relaxants. These can be used either topically or orally. The final step is to use non-pharmacologic approaches, non-opioid pharmacotherapy, and 3 to 5 days of short-acting opioids. It is important to note that there is no absolute safe dose of opioids, and it can take only 3 days of opioid treatment to see an increase in the risk of acute therapy extending into long-term therapy. As a result, opioids should be prescribed using the lowest possible dose for the shortest possible time. The Arizona Controlled Substances Prescription Monitoring Program should be checked before initiating an opioid or benzodiazepine, and then regularly thereafter. The safe storage and proper disposal of these medications should also be reviewed with the patient. It is of utmost importance to remember that the FDA has a black box warning against the use of opioids and benzodiazepines together. Treatment should be focused on a patient's return to function, and clinicians should encourage patients to stay active and at work when appropriate. For patients with chronic pain, the approach is a little different. Because chronic pain is a multidimensional issue, successful management requires addressing the whole person in an integrated fashion. Optimizing treatment of common comorbidities such as insomnia, diabetes, psychiatric conditions, and others is crucial when treating patients with chronic pain. Interdisciplinary pain rehabilitation has been shown to be the most effective and cost-effective for treatment of patients with significant functional impairment due to pain. For those taking opioids for chronic pain, reevaluation should be done regularly to prevent adverse outcomes, keeping in mind the primary goal for a patient with pain is maximizing function and minimizing pain-related suffering, rather than the elimination of pain altogether. This can be done with face-to-face visits every 90 days, utilizing the prescription monitoring database, and through urine drug tests. Also remember that for chronic pain, long-term opioid therapy has not been shown to be associated with sustained improvement in pain or function when compared to placebo or other medications. Enhancing self-efficacy through self-management strategies is the foundation of chronic pain care and the goal at every stage of treatment. There are 2 types of therapies for a person with chronic pain: active therapies and passive therapies. Active therapies are done by the patient and include self-care activities that promote physical, mental, social, and spiritual health domains. These have been shown to be effective in improving pain, function, and quality of life. On the other hand, passive treatments are done to the patient by the medical team and include things like medications, injections, and invasive procedures. These may perpetuate passive coping strategies, which are associated with negative mood and high levels of disability. There is limited evidence to guide strategies to prevent pain chronification, but early identification of risk factors and treatment with evidence-based therapies is advisable. Because long-term opioid therapy is associated with known risks and unproven benefits, treatment plans should include the development of a tailored opioid exit strategy, which transitions patients from long-term opioid therapy to a different treatment strategy. There are multiple strategies for this, and the best strategy for the patient must be guided by the socio-psychobiological assessment of the patient. Some of these strategies include tapering the opioid dose, rotating to buprenorphine and then gradually tapering the buprenorphine dose, or arranging medication-assisted treatment for a patient with opioid use disorder. Abrupt discontinuation is generally not recommended. Similar to patients with chronic pain, the treatment of opioid use disorder requires a whole-person approach, addressing social, psychological, and biological aspects of the disease. The treatment course is typically lifelong. Psychosocial therapy should be individualized for each patient. For those who express interest in discontinuing or diminishing use, the same behavioral approaches to other chronic or lapsing conditions should be applied, such as working with patients to encourage motivation to change, rewarding cooperation with treatment, working to keep motivation high, and teaching ways to minimize relapse to drug use. In addition, pharmacotherapy for opioid use disorder is effective and should be offered to all patients. Pharmacotherapy for opioid use disorder is underused, and there is a common misconception associated with pharmacotherapy that it substitutes one addiction for another. In fact, these medications such as methadone, buprenorphine, and naltrexone help stabilize the neurobiological imbalances present in opioid use disorder, which allows patients to engage more fully in their recovery. They can help reduce or eliminate cravings for opioids, reduce illicit use, reduce the risk of HIV and HCV infections, and they increase treatment retention. Pharmacotherapy can reduce opioid overdose deaths and all-cause mortality compared with psychosocial treatment alone. Duration of therapy should be considered indefinite, as there is a high rate of relapse and overdose deaths after leaving treatment programs. Keeping this in mind, patients should be taught that relapse is a process, and members of the care team should work with the patient to identify triggers for relapse and coping strategies to either avoid or manage these situations. In addition, naloxone should be considered a key aspect of opioid use disorder treatment, and it should be prescribed to all patients while educating patients, family, and social support about its use. Naloxone is a medication approved to reverse an overdose by opioids, and there is moderate evidence that take-home naloxone programs are effective at improving overdose survival and decreasing mortality. The withdrawal of opioids can be very uncomfortable and distressing, but it is rarely a medical emergency except in the setting of pregnant women and neonates. The acute withdrawal syndrome can be thought of as experiencing gastroenteritis, severe influenza, arthritis, fibromyalgia, anxiety, impending doom, insomnia, and dysphoria, all at the same time. These acute symptoms are often followed by weeks to months of a protracted withdrawal syndrome that includes anxiety, depression, fatigue, anhedonia, sleep disturbances, dysphoria, irritability, and pain. The management of opioid withdrawal can and should be managed with both pharmacologic and pharmacologic approaches, such as meditation, relaxation, and deep breathing. Treatment and withdrawal should not be performed in isolation and should always occur in the context of a long-term treatment plan, usually with pharmacotherapy for opioid use disorder. There are a number of different ways to treat the symptoms of opioid withdrawal symptoms, as described here on the screen. Finally, factors such as overstretched systems, lack of resources or time, clinician characteristics such as communication style and compassion fatigue, and patient characteristics such as patient expectations and psychosocial history can all contribute to making a clinical encounter challenging. People-pleasing behaviors such as providing a prescription to avoid hurting someone's feelings or to avoid a negative patient satisfaction score can sometimes be difficult to prevent. However, these lead to worse patient outcomes to include higher rates of hospitalization, higher healthcare expenditures, and even higher death rates. In order to account for these factors, it is always important to manage difficult interactions as best as possible. Some tips include planning interactions in advance, paying attention to patient nonverbal communication, identifying emotions and meaning behind the patient's words, maintaining clinician self-awareness, and always maintaining a mindset of how to best help the patient. We would like to thank you for watching this video. Now please stick around for a short quiz to ensure comprehension.